My name is Jeremy Davis, and I'm going to be talking to you today about surgery in the treatment of stomach cancer. So as an outline, today we're going to talk about the why, which is why do we use surgery in the treatment of stomach cancer? Well, we'll talk about staging, diagnosis, and treatment. We'll talk about the when, which is the timing of surgery. We'll talk about the what, meaning the extent of the operation. And then the how. There are some controversies in the management of patients with stomach cancer, and we'll touch on those. And then the last is who else might be a candidate for surgery with stomach cancer. So I'd like to start off with a clinical scenario. And this is a typical scenario of a 60-year-old person with a family history of colon cancer. And they were found to have anemia. So in the workup of their anemia, they underwent a colonoscopy, which showed no polyps or evidence of cancer. So when that happens, oftentimes the next step is an upper endoscopy. And in this case, that was performed and showed that this person had a mass in their stomach with some concerning features of ulceration. A biopsy was done and showed adenocarcinoma. And remember, adenocarcinoma is the most common form of stomach cancer. And when we talk about stomach cancer, we're talking most often about adenocarcinoma. So what's next? So many of you may know that oftentimes when someone's diagnosed with a cancer, they get a CT scan or a CAT scan. And this is to look for evidence of spread of any cancer beyond the stomach. Oftentimes people will undergo a PET scan also. A PET scan is another way of looking for evidence of spread of cancer beyond the stomach or where it started. But what else can or should be done? And this is where surgery actually can play a role in both the diagnosis and treatment of stomach cancer. And that's laparoscopy. So laparoscopy is basically when we put instruments into the abdomen after we filled the abdominal cavity with gas, basically to blow it up so that we have room to work inside the belly. So what's the role of laparoscopy? Well, really the role is to look for something called carcinomatosis, and this is cancer that has spread to the abdominal cavity. Now, laparoscopy in stomach cancer is able to detect cancer deposits that are too small to be seen on a CT scan. So basically a CT scan may be done and it may be negative, but about 1 in 5 patients with stomach cancer may have carcinomatosis even when their CT or PET scans are negative. What we do at the time of laparoscopy is, besides looking around, is we put fluid or saline solution in the abdomen and wash it around. And when we look at that fluid, we can sometimes find microscopic cancer cells in that fluid. So what this does is laparoscopy allows us to avoid unnecessary surgery in about 1/3 of patients with stomach cancer. What this does is it allows us to accurately stage patients with stomach cancer so that we can select the most appropriate treatment and avoid any delays in starting therapy. So what does it look like when we do laparoscopy? Well, in the abnormal setting, this is what we might see. These little white plaques or dots in the abdominal cavity. This is the liver and this is the abdominal wall. Here again is a piece of intestine down here, the colon, and this white plaque is a cancer deposit. And these are too small to be seen. So surgery can play a role very early in the diagnosis and staging of stomach cancer. Well, let's talk in general about the timing of surgery, though, if someone is diagnosed with stomach cancer. Well, the most important thing to know is that treatment overall, or surgery for the treatment of stomach cancer, is based on what we call stage or clinical stage. And I'd like to break this down into 3 stages: early stage, middle stage, and late stage. And the middle stage being these stages 2 to 3, where most patients in the United States will probably be diagnosed in this range. Well, early stage stomach cancer is often treated with surgery first and oftentimes surgery only. In middle stage stomach cancer, we treat most patients with a combination of chemotherapy and surgery, and sometimes with radiation. Late stage stomach cancer is oftentimes treated with chemotherapy alone, and usually there's no role for surgery, although surgery may be used in the palliative setting, and we'll talk later about the role of surgery in stage 4 gastric cancer. The next thing to understand is the sequence of surgery and chemotherapy, meaning which should come first, surgery or chemotherapy? Well, you could do surgery first, and then you have to follow up with a full course of chemotherapy, especially for patients diagnosed in that middle stage. But this isn't the standard in the United States. You could do all chemotherapy followed by surgery. And this isn't yet the standard, but it may become the standard, at least not yet in the United States. The other option is to do some chemotherapy, then some surgery, and then some more chemotherapy. And this is actually the current standard in the United States and most Western countries. So now let's say a patient has been diagnosed with a middle stage gastric cancer. It's decided that they're going to get chemotherapy, then surgery, and then chemotherapy after surgery. How do we decide how much surgery we're going to do? So what's the extent of the gastrectomy? Well, these are kind of the 4 general options. A distal gastrectomy is based on whether or not the tumor is located low down in the stomach, as indicated here, and if so, you would remove the lower part of the stomach and leave the upper part. The other option is to do what's called a subtotal gastrectomy, and this is for tumors that are located higher up in the stomach where we can't take or where we need to take a little bit more of the upper part of the stomach. A total gastrectomy is where we remove the entire stomach, and this is often done for tumors that are located high up in the stomach. Wedge resections of the stomach are rare for stomach cancer, at least in the United States. These might be used for more benign tumors or other kinds of rare tumors of the stomach. So we're going to focus right now on these 2 because these are probably the most common operations for stomach cancer, a distal gastrectomy or a total gastrectomy. Well, after you take that part of the stomach out, you have to put it back together. These 2 types of reconstructions here, called Billroth 1 and Billroth 2, are really just reconnecting the intestine to the stomach after you have removed part of the stomach. However, I'm going to focus just a few minutes here on the total gastrectomy reconstruction, which is called a Roux-en-Y. Roux was a Swiss surgeon, whereas Billroth was German. Roux-en-Y refers to this reconstruction method here, and we're going to talk just a minute here about this connection between the esophagus and the intestine. That connection, called an anastomosis, is considered usually the highest risk part of a total gastrectomy, but an anastomosis can refer to any connection of bowel to stomach. Now I'm going to show a few pictures of surgery here, so a warning for anybody who may want to turn away. This is what it looks like after the stomach has been removed. The stomach is gone, left over is the spleen here. These are arteries going to the liver and to the spleen and the pancreas down below. And that yellow arrow points to the esophagus, which is just poking through this structure called the hiatus. And then we bring up a piece of intestine, which is this nice salmon pink colored piece of intestine that's sewed to the esophagus right here. Now I'll show a video that's going to show you just how we connect those. And it's important for people to know that the removal of the stomach may be very straightforward, and that's usually not a very complicated part of the operation. But then putting this intestine back to the esophagus, which is happening now with the help of this stapler. That device fires titanium staplers or staples that connect the intestine to the esophagus. And then, at least in my case, I use additional sutures to sew the remaining little hole back together, and that's what's happening here in this video. This part of the operation, I think, is the most important part of the operation, and this is where much of the morbidity or potential for complications comes from. If you get an X-ray when you're done, this is an example of what it looks like. Esophagus here connected to intestine here. So what should patients expect after they've undergone a gastrectomy? Again, whether this is a total gastrectomy or a subtotal gastrectomy or even a distal gastrectomy. Well, oftentimes these operations can take anywhere from 2 to 4 hours, and that's most common. External drains or feeding tubes are generally not needed, although this is always determined on a case-by-case basis, and your surgeon may decide to use one of these based on other things that happen during the course of the operation. But in general, people should expect to be up and walking the day after their operation. And most people are able to eat solid food within about 4 to 5 days after surgery. Again, it depends on the extent of the operation. But the typical hospital stay is about 5 to 7 days. And again, this may be adjusted slightly based on the extent of your operation. Now, I would like to touch on the controversies surrounding the approach to taking out either part or all of the stomach. And the main controversy relates to the use of minimally invasive surgery, or specifically robotic surgery. And I took this advertisement off the web, basically, where people want to talk more and more about the use of robotics in surgery. Well, what does robotic surgery look like? Well, it kind of looks boring, I think, a little bit like this, where you have a surgeon sitting over here all by him or herself, and they're far away from the action. The action is maybe about 10, 12 feet away. You can't even see the patient laying here under these blue drapes. You have this big robotic machine hanging over the patient. There are people at the bedside to help out, but the surgeon is sitting over at a console doing the operation without actually touching the patient. So when we talk about robotics, and generally what we're talking about is laparoscopic or robotic surgery, and we're usually comparing that to open surgery. And that's because open surgery is considered the standard. And so any studies that are wanting to compare laparoscopic or robotic surgery are comparing them to open surgery. Now, the best studies in open or robotic surgery usually come from Asian countries like Japan and Korea, where gastrectomy is very common. Almost all of these studies from Asian countries show that laparoscopic gastrectomy is equivalent to open surgery. This means when we look at things like complications, recurrence of cancer, or even overall survival. Now, there may be reasons why results from Asian studies may not be applicable to patients in the United States. And this is generally because gastrectomy is a less frequent operation in the United States compared to Asian countries where gastric cancer is much more common. Now, cancer in the stomach is generally diagnosed at more advanced stages in the United States, and patients in the United States generally have higher comorbidity rates such as obesity and diabetes. So people are usually cautious when we compare studies out of Japan, Korea, or China to patients in the United States. So what are the data on laparoscopic versus open gastrectomy for gastric cancer? Well, first thing to know is that many studies have focused on short-term outcomes. These are things like blood loss, length of hospital stay, and in these studies, the differences are usually quite small. Long-term outcomes, however, meaning survival or cancer recurrence, generally show no real differences. So the advantages in laparoscopic or robotic surgery seem to be on short-term outcomes. But again, most studies show that laparoscopic surgery for gastric cancer is equivalent to open surgery. What does that mean? It's not better, it's not worse. But you should remember that all these studies are generally looking at when laparoscopic or robotic surgery is performed by experienced surgeons. And most studies in the United States are not randomized controlled trials, which would be the most rigorous form of analysis. However, there is one recent study that I think people should be aware of, and you can always talk to your doctors about this, and this is the Logica trial that was recently published from the Netherlands. And the take-home point here is that there was no difference in laparoscopic versus open surgery in terms of length of hospitalization, readmission to the hospital, no difference in complications or survival. And I think this is a very well done study in basically a Western or non-Asian population of patients with stomach cancer. So the last part I'll talk about is, are there other roles for surgery in gastric cancer? Well, surgery for stage 4 gastric cancer is not common. I told you that in the very beginning of this conversation. However, there are cases where patients' tumors may be bleeding or causing obstruction that can't be addressed by chemotherapy or radiation, and that's where surgery has long played a role in late stage or advanced gastric cancer. However, there are investigational applications of surgery in stage 4 gastric cancer, and specifically the delivery of intraperitoneal chemotherapy, such as HIPEC or PIPAC. And I stole this nice picture off of the internet because I thought it did a very nice job of showing you the idea. So what are we trying to treat when we talk about surgery for advanced gastric cancer? Well, we're talking again specifically about peritoneal carcinomatosis. This is a tumor that is metastasized or spread to the abdominal cavity. And as I mentioned earlier, this may be present in about 30% of patients at the time of diagnosis. And unfortunately, even when we operate, the chance of recurrence can be up to 40% after chemotherapy and surgery is done for stomach cancer. Now, targeting therapies directly to the abdominal cavity is difficult, especially when you give chemotherapy through the IV. It goes throughout the body. And if you want to target the abdominal cavity, that's difficult and often requires surgery. So HIPEC and gastrectomy for cancer, I would say, encompasses this idea of targeting the abdominal cavity. And what patients should know is that clinical trials are ongoing to determine the efficacy of this kind of treatment. Most of these studies have typical eligibility criteria. This is that they usually require upfront treatment with systemic chemotherapy. So most patients will have need to have received IV chemotherapy. And the other thing we look for is limited peritoneal carcinomatosis or metastasis, meaning we want to see that there's relatively a low burden of cancer in the abdominal cavity, and this is based on something called the PCI score. Now, there are variations to intraperitoneal chemotherapy. So HIPEC and gastrectomy with cytoreduction means that you go in and remove the stomach, all tumor that you can see, and then you apply this heated chemotherapy into the abdominal cavity. There are also studies looking at laparoscopic HIPEC, which is where you deliver that heated chemotherapy through small tubes inserted into the belly, but there's no surgery to remove the stomach or any tumor. There's PIPAC, which is a pressurized chemotherapy where the chemotherapy is aerosolized and delivered under high pressure. And then there's chemotherapy that's delivered through an intraperitoneal port, kind of like a port that you would have to deliver chemotherapy into your vein, but this one goes into the abdominal cavity. So what does it look like if someone undergoes one of these therapies? Well, usually they've been diagnosed with stomach cancer. They've had staging that shows that there is spread of the tumor to the abdominal cavity. So they go on to get systemic chemotherapy, which is the standard. But at some point, they may have restaging or repeat scans that show that the tumor in the abdominal cavity is stable or responding to therapy, and then they're referred to a clinical trial. And this is where you have that determination of study eligibility. But if patients are eligible for the study, then they may go on to get, whether it's HIPEC or PIPAC, with or without their gastrectomy, and then followed up as part of a clinical trial. So in conclusion, we talked about the who in terms of surgery. Well, most patients who get surgery for stomach cancer have either early stage stomach cancer, stage 1, or stage 2 and 3 stomach cancer where they've had chemotherapy in combination with surgery. And again, it's uncommon for patients with stage 4 stomach cancer to get surgery, except usually on a clinical trial. We talked about the when. Well, surgery is usually used in combination with chemotherapy. In the United States, that surgery is sandwiched usually in between chemotherapy before and then chemotherapy after surgery. And then we talked about the what, the extent of surgery, which is determined by the location of the cancer in the stomach. So whether you get a partial gastrectomy or a total gastrectomy will depend on the location of the tumor. And then we talked about the how. The open approach is still the most frequent approach in the United States, although laparoscopic or robotic surgery is shown to be equivalent to open surgery, again, in experienced hands. So that's an important thing for patients to remember. And with that, I'd like to thank you for your time and attention, and I'll happily take any questions.